Good afternoon, everyone, or morning if you're on the West Coast. Thank you for joining us today. We're excited to bring you the fifth webinar in the NIA Data Linkage Program's 2024 webinar series. Today, our featured topic is the Rush Alzheimer's Disease Center, or we refer to it as RADIC. Next slide. The agenda for today's call will start with brief introductions, webinar logistics, followed by a brief overview of the NIA Data Linkage Program, and that'll lead us into our featured topic, which is RADIC, or Alzheimer's Disease Center. At the conclusion of the presentation, the panel will have ample time to answer all of your questions and answers. By way of introduction, I'm Susan Seifert, the Program Director of the NIA Data Linkage Program, and I'm joined today by Brian James and Fran Grodstein from Rush University. Given the webinar format, we ask that our team is requesting that you submit your questions via the Q&A chat bot at the bottom of the navigation pane. The panel will do their best to answer all of the questions, but should there be any questions remaining, we'll be happy to follow up with you following this session via email. Now, for a brief introduction to the NIA Data Linkage Program. NIA established the linkage program to address three major challenges that researchers face relative to gaining access to CMS data for linkage to their study. The first challenge is the time and cost for researchers to access the CMS data. To overcome this challenge, NIA collaborated closely with CMS to structure this program in a way that is able to provide quicker access to the CMS data without the researcher incurring the large data fees that are associated with getting data through CMS directly. One condition, however, is that the researchers must use the CMS linked data in a federally authorized system that complies with all the federal data security requirements. Finally, NIA recognizes that not all researchers are experts in the use of claims data. Through the Data Linkage Program, we offer knowledgeable CMS data support staff to assist researchers. Next slide. Building on these challenges, the primary goal of the NIA Data Linkage Program is to facilitate high-impact research in the area of health and aging while minimizing the effort and cost of accessing that CMS data. This slide shows our comprehensive library of CMS data. We offer the Medicare enrollment data, parts A, B, C, and D, as well as the CMS assessment data, the MDS, OASIS, and IRF-PI. And finally, we also offer Medicaid data. The CMS and study data is delivered to researchers in the Linkage Enclave, which is a set of secure workspaces where researchers are able to analyze the CMS linked study data. Each project gets a dedicated project environment which is accessible to only authorized members of the research team. The Linkage Enclave offers a variety of statistical software packages such as MATLAB, Python, R, SAS, SPSS, and Stata. It also features a proprietary tool called the Job Board, which is a load-balanced, high-speed server farm, which can be utilized to run your statistical programs, often in substantially less time than running the programs locally. The Enclave features a file transfer tool that allows transfer of files into and out of the Enclave. Importing files is generally restricted to code or supplementary files that are needed to conduct your research, all of which is generally approved by the study team prior to importation. Exporting requirements are aimed at supporting dissemination of your research findings. It's a bit more restrictive than the importation of files. The data exports should be at aggregate level with no PII, PHI, or small cells. Please note that the data transfer into and out of the Enclave requires review by both the NIA Data Linkage Program as well as the study to ensure that the integrity of the research is being met. The NIA data linkage program offers a three-pronged support structure. First, the linkage contractor offers access to and support using CMS data, as well as enclave support. NIA provides support through not only the support of the linkage program, but also reviewing and approving the NIA DUA for the CMS data. And of course, our wonderful study partners provide their expertise in using their data. The linkage team can be accessed through email or via phone Monday through Friday from 8 p.m. to 8 a.m. to 8 p.m. Eastern Time. And we're happy to answer any general questions and provide any kind of support that we can. I know this was a lot of information about the NIA data linkage program in a very compressed time. Our team is always happy to entertain any questions that you may have either following the presentation or via email following this session. Now, without further ado, I'd like to introduce Brian James, and Fran Gradstein will follow Brian in the presentation of Rush University's Alzheimer's Disease Center data.
Just thanking the rest of the RDC faculty and staff. Next slide. Specifically, our Medicare linkage team is me, Fran Gradstein, who you'll hear from soon, Yi Chen, who's done amazing work putting this all together for us. Anna Capuano is our senior statistician. Brittany Langmaya, who's another epidemiologist. And both Fran and I are both epidemiologists as well. And we'd love to thank, we couldn't do any of this without the funding from the NIA. We have two R01s that are currently funding our linkage program. One's led by me with Melinda Power at GW University, and the other one is Fran's grant with Julie Bynum at the University of Michigan. Next slide. So if you're interested in using RADC data or specimens, we have a hub that my team put together. It's at radc.rush.edu. You can look at all of the data that we've collected in our cohort studies. I'm going to describe to you our cohort studies in a minute and some of the data that we collect. And all right, so these are the 5 main RADC cohort studies that we're working with. The religious order study, which are actually Catholic nuns, priests, and brothers from 40 groups nationwide. And this was the first study that we started back in 1991, I believe. There's the Memory and Aging Project. So these are older adults, not nuns, priests, and brothers, just laypersons from retirement communities and senior housing facilities throughout. And this is just based in Chicago. All of the rest of the studies are just based in Chicago. We, because Ross and MAP are predominantly white, we actually started the Minority Aging Research Study in the early 2000s, and that is the same exact main cognitive battery and things that I'm going to explain to you that we collect, but in African American participants in Chicago. We also have the African American Clinical Core, which is a similar design, and then we have the Latino Core, which is our newest study, who are self-identified Latino or Hispanic older adults in the Chicago area. So we have a bit of diversity across these 5 cohorts. We collect all sorts of things annually. We go to people's homes. We do a cognitive battery of 18 neuropsych tests. We do a classification based on the cognitive battery of whether they have normal cognition or if they have mild cognitive impairment or dementia. All sorts of measures of lifestyle and behavior. We have a lot of measures of health, but they're mostly performance-based or sensor-based or just self-reported, right? So as I'm going to talk about, there's a lot that we don't know about people's health that we're using the Medicare claims to supplement. We have all sorts of biological data and specimens that we gather. We have genetic information. We do MRI scans on people, both while they're alive and then after they pass away. We actually I'm going to describe the autopsies that we do, but we actually do MRI scan of their autopsy brains as well. We have stored blood samples from each of the annual blood draws, and we have these brain specimens. So for the Ross and MAP, a requirement of being in these studies is that they agree to brain donation at the time that they pass away. For the other minority studies, it's actually volunteer. So we try very hard to obtain that consent, but because we know that that can be an obstacle for recruiting minority participants, we make it volunteer. But more and more people are volunteering to donate their brains. And we get a postmortem neuropathological battery. We get measures of Alzheimer's disease and other neurodegenerative and vascular pathologies. And you can see a timeline here. This is on the hub that I described of when each study started. They're all ongoing, so they're all still recruiting people and collecting data, and we follow people as long as we can until they pass away. Next slide. Just briefly, I mean, one of the strengths of our study is the amazing pathological data that we have. You can request the actual specimens. Obviously, they are very valuable, so you have to have a really good, scientific argument for, if you want to access the hippocampus, for example, it's a valuable piece of specimen. But we also have all sorts of data that we've collected on these brain samples that we freely share with people. So you can get counts of plaques and tangles and things like that, easily requested. Next slide. So that all being said, we gather all this incredible information at these annual visits, but we realized we were missing so much information on people's health beyond their cognitive ability. We have a lot of self-reported measures of vascular disease, but obviously self-reported, yes or no questions has their limitations. So, years ago, I think it was in 2008 was when we first linked to Medicare claims to really supplement the data that we collect in these cohort studies with all of this information, diagnoses, every single time people go to the hospital, every time they interface with their doctor, procedures, so many things that we cannot get just from asking people on a survey. So the claims data has been just a wealth of information to supplement what we collect. We have, across those 5 cohort studies, we have about 5,200 participants right now. Obviously, we recruit new people every day, so that number keeps changing. And at the time that we last got our Finder file to Acumen to link to Medicare, we had about 84% of those 5,200 people had consented for Medicare linkage. And we're hoping to grow that percentage every single year. And we are actually increasing that percentage every year. So we have about 4,300 people linked to their Medicare claims on the Enclave. And, after the Finder file, all the dust was settled, we about 4,291 were linked. And then if you, obviously you have to have the fee-for-service coverage for a lot of the work that we do. We have Medicare Advantage now, which is fantastic. We're still learning how to work with it. But for most of the work that we've done so far, we're just using the fee-for-service coverage. And so we require at least a year of fee-for-service coverage. And we have about 4,000 people with that linkage. Next slide. So this is the number of people broken down by cohort study, linked to their claims that we have on the Enclave that you can access right now for Medicare claims data from 1991 through 2022 at the moment. And then it shows you the percentage of the cohort that have consented to linkage to their Medicare claims. The lowest is the MARS study, as you can see, it's only about 50%. And that's because we actually have a completely separate informed consent process for Medicare claims, as opposed to it being part of the overall consent process for the other studies. So that's why it's a little bit lower, because the more information you give people, the more skeptical they get. And they say, why am I signing this? But we are doing a great job. Our coordinators are getting people's buy-in. I'm giving presentations to the MARS participants, and we're growing that percentage every year. And then you can see the number of person years that we have across all of these studies with Medicare claims. Okay, next slide. Susan already laid out all of the Medicare claims files that you can get, but this is a breakdown of the ones that we use most frequently. We've got the A and B claims. We really use that MedPAR file a lot because that is hospitalization data. We are just starting to work with the Part D claims. We just hired an analyst who has some experience working with prescription drugs, and we're really going to work that into what we do. I should say we do a medicine cabinet check with our participants every year. So as part of the annual visit, we see all the medications that they have in their medicine cabinet. But of course, that's only once a year. and people are prescribed all sorts of medications over the course of a year that you might not see with an annual check. So having, every single thing that they were prescribed through Part D accessible is, again, just an incredible wealth of information. Next. Um, the steps to request and access the linked RADC Medicare files, it's kind of a two-part process. So it's all laid out. If you go to our hub and you go to Medicare claims, it lays out the whole process. But basically, the first thing you need to do is you need to contact us, me, about your intention to use the linked claims. And we can have a discussion because I often get people contacting me and they have a really cool idea, but it's actually not really doable for whatever reason with the linked claims that we have. So I have to, a lot of people have ideas of what's in the Medicare claims that aren't actually in there. So we have to kind of do some upfront work on their scientific hypotheses before we before we know if it's going to work with the linked data. So supposing that it actually is a great question we can answer with Medicare claims, you then submit a request through the RADC hub, just like you would if you were using Rush data, RADC data having nothing to do with Medicare, but you just will specify that you will be using the Medicare claims through the enclave in your request. Then you establish a data use agreement with Rush, with us. Then you do the process that's laid out on the NIA page, the linkage page. You have to complete a DUA with NIA as well. And then you receive approval by the NIA board and you get access to the linkage enclave. So sounds like a lot of steps, but I think both Rush and NIA have really streamlined this request and DUA process. And from working with a few people that have done this, it can go pretty smoothly, like just a couple weeks to, if you're lucky, to up to a month. But that's, if it's slow, but it can be pretty quickly. And I'm here to help on the Rush side, and of course the linkage support, as they said, are there to help on the NIA side. Next slide. All right, so that is really it. That's what we wanted to tell you about the linkage that's available. And now we're going to show you some of the work that we've actually done with this Medicare linkage. I'm going to present a paper that came out of my R1, and then Fran's going to jump on and talk about a paper from her R1. But it just gives you an example of what you can do with this cohort data linked to Medicare data that you wouldn't be able to do with either of the data sets alone. But there's all sorts of questions that we have not even, it's the tip of the iceberg that we've touched. These are some of our published papers, and we're just going to talk about two of them here. Next slide. All right, so here's the first example. This is from my R1, which is on predictors and consequences of the timing and accuracy of clinical dementia diagnosis. And what we did with this grant is we took advantage of the fact that we do an annual assessment in our cohorts to see when people first develop dementia, right? And we can use that as kind of a gold standard for the onset to the year of dementia onset, right? And then we can compare that to people's Medicare claims and see when a medical provider actually gave them a diagnosis of dementia in the healthcare setting and look at the length of time in between those two events. So, and then we can look at what predicts someone getting a timely diagnosis, which means, a claim that's close to the cohort diagnosis, as opposed to a late or even a missed diagnosis of dementia. So that was, right. So go back one slide real quick. Sorry, Fran. Just wanted to say this is published in Alzheimer's and Dementia. Yi Chen was the first author, and we're going to present the results here. Okay, next. The quick background here is that about 50% of people with dementia are actually not diagnosed as having dementia in the healthcare system. That's been laid out. And many experience a missed or even a late diagnosis. So, in the past, people have looked at misdiagnoses, but there hasn't been a lot of research on a late diagnosis and what that means, right? And what predicts you getting a diagnosis, but 2 years after you actually develop the symptoms of dementia. Next slide. So to better understand who is diagnosed by the healthcare system in a timely fashion and when, again, we use these I've already described how we link the cohort data to the Medicare data using the enclave. And then we looked at the factors, both using cohort data and Medicare data, that is related to the timing of diagnosis. Okay, next slide. Um, so again, we just compared a timely diagnosis to what we're calling underdiagnosis. That's either late or a misdiagnosis. And the timely window was based on a window of if someone developed dementia in the cohort study, they were assessed as adjudicated as having dementia in a given year. We looked 3 years back in their claims, and we looked 1 year forward to see if there was any claims diagnosis of dementia based on ICD-9 and ICD-10 codes. And if it was more than a year after, then we called it a late diagnosis. Okay, next slide. Oh, this is just this is just a visual of what I just said. All right, next. Oh, I think the red dots are going to pop up. Yeah. So if the red dots pop up there or there, then we're going to call it a timely diagnosis. If it's over there, it's a late diagnosis. Okay. So here are I don't have a lot of time left, so just we looked at a whole host of socio-demographic, health, and psychosocial predictors of a timely diagnosis. Most of them came from the cohort study, except for the Elixhauser data and also the healthcare use data. So, we didn't want people who just happened to see a doctor more often. We wanted to know if that was predictive of people getting more timely diagnosis. Kind of it's like a confounder. All right, next slide. Now, before I show you the results, I would, I'll ask you to think about what you think will be the predictors of someone getting a timely diagnosis or not. Because to spoil my own thunder a little bit, very few things actually predicted it, but the ones that stood out, we were not surprised by. So press down because it's going to put a little box up. Fran. Oh, no. Yes, right here we go. So again, we see about 54%, just like I said in the beginning, receive a timely diagnosis, meaning that about half of people don't get a timely diagnosis. Hit down, please. There we go. So, and this is just showing bivariate comparisons, and then I'm going to show you the adjusted comparisons. But one of the things that stood out, and I don't know if you thought about this in your head when you were thinking about what would be related, was race and ethnicity. And it turns out that Black participants are less likely to get a timely diagnosis. Next. And also income. So people who had less income were less likely to get a timely diagnosis. Probably not that surprising, unfortunately. All right, next slide. And we didn't really see a lot else other than cognition. Yeah, okay. So people who, this is not that surprising, but people who were had better cognition, better cognitive function at the time that they were diagnosed, were less likely to get a timely diagnosis, right? Because the doctors, the more further along you are, the more likely a doctor is to say, wait, this person has dementia. Next slide. Or next box. Yes. And we also saw with Elixhauser, so people who were less healthy were more likely to get a timely diagnosis, right? Because again, doctor probably more likely to be looking for something that's going on with you. But we didn't see anything else other than what was in those red boxes. Nothing else lit up as predictive of a timely diagnosis. Next slide. So this is just showing the results of the adjusted analyses. So we put all of these factors into one model to see if things were independently related to the odds of having underdiagnosis. And again, what we see is that Black race was the main predictor. So our Black older adults were unfortunately about more than twice as likely to have underdiagnosis, either a late or a misdiagnosis of dementia in their healthcare claims, in their Medicare claims. Next slide. And then even when we adjusted for education, cognition, Elixhauser, all that, you still see the same relationship with race. Next slide. And then even adjusting for income, it didn't do anything to attenuate the association of race. and underdiagnosis. Next slide. Yep. All right, so that is really it. In conclusion, half of older adults with incident dementia were not diagnosed in a timely fashion by the healthcare system. Black older adults and those with lower income were more likely to be underdiagnosed. And other than cognitive function and comorbidities, few other factors explained underdiagnosis. And again, we really couldn't have done this study without the combination of the Medicare claims and the cohort data that we have access to. All right, I'm going to turn it over to Fran to present her work.
Thank you, Brian. So again, just to emphasize, our goal here is not to present our research exhaustively, but more just to give some nice examples for everyone as to ways that the linkage of the RADC cohort and the Medicare claims data can be done. So this is some ongoing work, which is not yet published, where we looked at differences in people with dementia, with mild cognitive impairment, and with no cognitive impairment in terms of how they use the ambulatory care system. And this was an interesting question for us because, especially recently, there are numerous care initiatives helping to support those with dementia or mild cognitive impairment, with two examples being Medicare's pilot testing of a program called the GUIDE model, which targets not just those with dementia, but their caregivers as well. And in addition, as I'm sure everyone has been reading lately, there's more and more therapeutics becoming available to delay cognitive decline targeted at those with mild cognitive impairment. But obviously, you have to interact with the healthcare system in order to take advantage of these initiatives. And there really was no research which had examined specifically outpatient ambulatory care in the community and how that's related to cognitive status. So again, we took advantage of the really detailed annual cognitive assessments in our cohorts, which let us every single year really rigorously classify those who have dementia, those who have MCI, and those with no cognitive impairment, or NCI. And then, of course, through the linkage with the Medicare claims data, we can look in detail at outpatient ambulatory evaluation and management visits in the community. And so for each participant, for each year, we looked at their cognitive assessment in the cohort. And then in the following year, we looked at their use of E&M visits. And again, because of the claims data, we could even look at clinician specialties. So were they seeing primary care providers, a dementia-related specialty, other medical specialties, or providers with a surgical specialty? And this is actually the only results slide I have, just again to keep things simple. But the results were really interesting when we compared no cognitive impairment, MCI, and dementia. First, when we look just at primary care providers. So again, this is the likelihood of seeing a primary care provider during 1 year time period. I mean, we did across the board see fairly high rates. It was about 86 to 92% likelihood of seeing a primary care provider annually. There were some small differences. Those with dementia, which is the darkest blue bar, had 86% likelihood of an annual visit compared to those with no cognitive impairment, where it was 92%. And this was a significant difference. MCI and NCI were statistically identical. But it does look like those with dementia are getting slightly less primary care. We also looked specifically at dementia-related specialists, which were geriatricians, neurologists, and psychiatrists. And here we actually did see that those with either MCI or dementia, so those are the two bars on the left, did actually have a significantly higher likelihood of seeing a dementia-related specialist compared to those with NCI. Although obviously, since we know these specialists are not incredibly common, overall rates of seeing these specialists were quite low, less than 20% per year for all three groups. Some of the biggest differences we saw were for other medical specialists. So although those with dementia and MCI are seeing a dementia-related specialist slightly more often, when we look at any other kind of medical specialist, those with MCI and those with dementia were clearly much less likely to see any other type of medical specialist than the dementia-related specialist. So we did really see some differentials beginning even in MCI with people getting referred to specialty providers. The surgical specialties again are generally less common, but nonetheless these differentials did appear there as well, with especially those with dementia not seeing surgical specialists very frequently. So overall, as I said, we did overall see fairly high utilization of primary care, regardless of cognitive status, although those with dementia did see primary care providers less than the other groups. Dementia-related specialists did appear to be utilized more often in people with dementia and MCI than NCI. But really was a striking finding, despite the fact that we know that people with dementia and MCI have more comorbidities than people with NCI, but nonetheless are seeing specialists less frequently than people with MCI. So again, just a quick taste of the kind of research that can be done with the linkage. And then just to close out, we really want to thank NIA as well as the linkage program and Acumen for all their support in making this kind of research possible. And for inviting us to present these research opportunities. As Brian mentioned, we really, really hope that investigators, around the country take this incredible opportunity to share these data.
Yeah, and we left about 15 minutes for questions. Hopefully we can answer.
Sorry. Actually, before we do that, I just did want to emphasize one further point. As Brian had pointed out in his initial introduction, attracting diverse participants is a really big mission of the RADC. And as Brian said, we have, three cohorts: the African American Clinical Core, the Minority Aging Research Study, and the Latino Core, which are exclusively devoted to doing research in minoritized populations. And as Brian noted, we do have lower rates of Medicare linkage in those three groups. However, the primary reason for that really is that those are our three newest cohorts, and we haven't even yet asked all of them for their consent to conduct the Medicare linkage. So we do know for a fact that as each year goes by, we are bringing in more and more of the participants from those minoritized cohorts in order to, have access for those claims data. So that's really the biggest piece of those low numbers is really simply that we, it takes a while to ask everybody for permission, and those are our newest cohorts. So, we are absolutely sure as time goes on that we will have, more and more of the minoritized participants to examine. Even though we're already quite high. And the results of both Brian and I showed you 25% of the participants were, just as in one example, African American. So, we still have very high representation of minoritized groups, which will only get bigger.
Yeah, and just to add to that, I mean, I mentioned it briefly, but I have found that when you actually present the research that you're doing with the linked Medicare claims and you show participants the reason that you're asking for this, access and what you can learn from it and what uh, the incredible, amount of information you can learn about the people in the studies and give back to them, that they say, oh, that's what you're using this for. That's why you wanted my social security number. Sure. Where do I sign up? So I think there's a very good reasons people have to say, why do I need to give you my social security or my Medicare beneficiary ID if they don't know what you're actually doing it for? Like they don't get that. We're just using it to link to your claims data, so that we can do this research on your health and it's all conglomerated. We're not looking at you specifically. It's all de-identified. I don't know which claims are yours versus another person. It's based on a random project ID. So once you explain a lot of that, you can build the trust and get over that barrier, hopefully in minoritized populations.